Our next speaker is Dr. Barbara Butzeck, which is slightly out of the order on your schedule, because Barbara has to catch a plane. I've known Barbara for many years now, and she's a consultant radiologist at the Groenemeyer-Institut in Bochum, Germany, where she works on the clinical application of MRI technology. I've known her for many years, as I say. She's chair of EFAF, trustee of Haemochromatosis International, and also chair of the German Haemochromatosis Society, and does her job. So don't ask me how she fits all that into her working life. She's also unique amongst our speakers, both today and yesterday, in that Barbara actually has hemochromatosis. So she was diagnosed in 2002, so she's very definitely on our side, and she's going to speak today on the subject of the clinical application of MRI technology.
Okay.
Thank you, Bob.
Good afternoon, ladies and gentlemen. Thank you very much, Howard, for the nice words and the introduction. Yes, I will talk about MRI liver plus FARI-scan, which is a special method to quantify iron in the liver. No, it was not orange, just after 2 sentences. Thank you. Okay, so I will shortly tell you a little bit about my institute, about the results, and I would like to share with you some case reports, which might be especially interesting for you, and come to a conclusion. So this institution is mainly a radiology institution, but we have 3 departments: radiology, microtherapy, and cardiology. And we have an interdisciplinary team, radiologists, orthopedic surgeons, general practitioners, cardiologists, anesthesiologists, and pain physicians. And we are working really as a team, and we have 3 MRI scanners, mainly for the diagnostics, and HCT scanner mainly for image-guided injections. And the focus of the institute is spine and joints, but also liver and joints. You might have problems with the joints, but today I'm not showing to you any pictures of affected joints. So, okay. So, how does it come that I opened a consultation? When I was diagnosed with hemochromatosis in 2000, I did not know anything about the disease. I'm a physician, yes, but after the next 10 years, I attended European Iron Club, BioIron, all these special congresses for iron metabolism, and so I spoke to at least 2,000 patients, and so I think I got a quite good experience. And the need of the patients in Germany, I could say, is to get more explanation for the disease. They go to specialists, to the cardiology, maybe to the orthopedic surgeon. They got reports, but nobody explains, nobody brings all these results together. So I think it could be a good job for me to explain, to do a little consultation. So between these 5 years, I saw 88 patients, mainly with high ferritin levels. From this were 58 patients with hemochromatosis type 1. Some of them were newly diagnosed, and some I got from my colleagues from the orthopedic department with problems suspicious to genetic hemochromatosis. So my job was mainly to checking all previous results, if needed, blood samples, MRI or X-ray, do a report with recommendations to give the patients something in their hand. They could go to their general practitioner or somewhere else. I need to have this, I need to have this. And referring so to other specialties. So to our radiology department, where we do this MRI with ferry scan, there were not only me. From these 88 patients, I did send 25 with unclear hyperferritinemia or for other reasons, I show you later, to the ferry scan, but also from hematologists or hepatologists with hyperferritinemia. They were sent to the MRI. So this is maybe a little bit special for radiologists. This is the protocol. The technique, the ferry scan, was invented in or developed in Australia, and so we do scans which we transfer to Australia. They have the software, and they sent back the results in 1 or 2 days. So I show you later some data. So maybe you have experience with MRI. So this is the machine, and this is the patient laying there. And for the detection, it's necessary to put a saline bag on the opposite side of your liver. And then you get back, usually with the MRI, without ferry scan, you get pictures like this. From a front view, you can here see the liver, the spleen, the kidneys, the spine, and the transverse or axial view, here the liver, and here's the spleen. So this is nothing special, but with the ferry scan analysis, you got a result with a number. Here you can see this can you see it or no? So it's 28.4 milligram dry tissue, and the normal range is up to 1.8. So this liver has a high iron storage. You may see from this scan the liver is black. This is the spleen. Usually they have the same grade of gray or black. If it's black, there you have a hint that there is iron in it. But you can, from this picture, you cannot say, is it high iron or low iron? So these are the numbers we investigated with the MRI ferry scan, and then we checked from all these patients. There were 13 homozygote, some were heterozygote, compound heterozygote. Some have a negative HIV genetic testing, and some had no testing. Okay, this table might be a little bit confused. I just want to show you the type 1 hemochromatosis. If you see the ferritin levels, they are having the highest one. So with compound heterozygosity, they could have higher levels. Even if genetic testing is negative, they could have levels. And from these also. So if you see this and then check transferrin saturation, what Professor Brissot told you in this morning, you can also find the highest values in homozygotes, compound heterozygous lower, maybe a little bit elevated, and here you are also could be in the middle, and with the LIC means liver iron concentration, you have in the type 1 homozygotes group, you have 1 with normal, but up to 30, and with the heterozygote, it might be a little bit higher, but not to this values. Okay. And we also checked for fat. Normal is lower than 5% in the liver. And here you can see then some have both. They have the type 1 genes, mutations, and 5 of them have also high fat. Okay. So I think this is mainly the same, just to show you again with type 1, the highest level of liver iron concentration. Okay, I will skip these two, which show pretty the same, and come to the first case. Male with 56 years. He had no disorders. He felt pretty much very healthy. In a routine checkup was found a ferritin over 2,100, high transferrin saturation. When he came to me, I found some swelling of his knuckles. You have heard of this, we call it MCP 2 and 3, second and third finger. And we did the HIV genetic testing, and he was homozygote. So, but he was a very busy man, management, and he said, so the recommendation was to undergo venesection. And he told me, no, I cannot, I feel healthy, why should I do that? And so to convince him, we did this MRI, and we found this 28.4 milligram. Normal is up to 1.9. So then he came to the second consultation 6 months later. He underwent the therapy. He took erythrocyte apheresis. I don't know whether you do this. It's a method where you, it's a little bit like dialysis for kidney diseases. The blood is thrown through a machine. The erythrocytes, the red blood cells are taken off, and the plasma you get back. And in one session, you could remove about double more iron than in a usual venesection. So he did that, and his ferritin came down to 161. And his question was, no, that's almost ready. I don't want to proceed. So we did another MRI ferret scan. It was really much, much better, but still a little bit about higher than the normal. So he proceeded in venesection. Okay, next case. Here we'll show you one case. Here's the transferrin saturation. Here's the liver iron concentration. Though here's a person with lower than 45%, normal range for transferrin saturation, but pretty high the liver iron concentration. So this was a male, 70 years old, with a ferritin of 1,580 and this low transferrin saturation, liver enzymes normal, and his GP said, no, it's not necessary to do HIV testing because of the normal transferrin saturation. Then actually he was forced by his sister, who had genetic hemochromatosis, to get checked. And then after special questioning, he complained about irregular heartbeat and joint swelling. So we did the X-ray and found typical arthropathy. Dr. Kiley will show you some pictures later. And together with this family history, we decided to do the genetic testing and do the ferry scan. So he was homozygote, and he had a ferry scan with a liver iron concentration of 11. So this both was helpful to convince him to undergo phlebotomy and to make the diagnosis. Okay. So third case, male, 60 years, first consultation, symptoms were fatigue, deficit of testosterone, osteoporosis, and knee pain. He had ferritin up to 850, light transferrin saturation 70%, liver enzymes normal, but he had a body mass index of 31. So, but with this and these symptoms, we did the gene testing. He was homozygote, and we did also the ferry scan, and he had slightly increased liver iron concentration, but also fat percentage of higher than normal, which is 5. So, and this is a special case because this person is living as a teacher in Siberia, and there he had no access to regular venesection. So he comes to Germany 2 holidays per year, and then he had, over 1 year, he had 6 phlebotomies. But because of his body mass index, we recommended also to do some weight loss. So he started cycling, changed his diet, totally abstinence of alcohol. So 3 years later, he came back, he lost 7 kilo. He complained less fatigue, less knee pain, and his ferritin with only 6 phlebotomies came to normal ranges. Unfortunately, we have no transferrin saturation. That's what we learned today. You should sometimes check for transferrin saturation. But this shows you that you could have genetic hemochromatosis plus fatty liver, and only changing diet, losing weight, abstinence of alcohol could lower your ferritin to normal ranges. So I just show you one female. Here it's the special thing was she had hip and knee pain, and her test was homozygote, X-ray, typical arthropathy of her hands. And what you else can see, not in an MRI of the liver, but I choose this, you can see a secondary finding, necrosis of femoral head, which leads in this person to hip replacement. Another case, I just want to show you the pictures. What you else can see, this is the black liver, full of iron, about 23.1 milligram. But you can also see iron in the heart muscle and iron in the pancreas without quantifying it. Okay, and the last case is a person, 66-year-old, with a ferritin about 5,000, high transferrin saturation, and he was sent to phlebotomy without doing any genetic testing, without a liver biopsy, and then he came to me 8 months later, and his ferritin was lower, decrease in liver enzymes. So we recommended genetic testing, but the genetic testing was negative. But he proceeded in venesection, and we did the ferry scan, and so we saw iron in the liver and the spleen. This is normal kidneys. But he has also fat inside the body, outside the body, and with a percentage of 15%. So I'm not ready with this case. I will definitely send him to further genetic consultation and investigations, and then I will follow. So in the end, I come to the conclusion that MRI ferry scan could be, it must not in every case, could be a good and helpful tool to differentiate hyperferritinemia, especially if you do additional fat measurement, and it could help to do the decision pro or contra phlebotomy or further investigations. The number of liver biopsy reduced anyway over the last years, and as you see from my case reports, it could raise motivation for the therapy, losing weight or proceed in phlebotomy. So this is my group, and thank you for your attention. Before the red flight. Thank you.